Good evening and welcome. Today we'll be learning about systematic reviews and meta-analysis from a professor of obstetrics and gynecology. A little bit tells me though that when next you see his name, you are likely to see the words MSc Physiology added to the various letters already behind his name. Please welcome with me Professor A.A. Adewunmi. Prof, sir, please take it away.
So we are discussing systematic reviews and meta-analysis this evening. And I'll be using the outline on the next slide. That will be introduction, steps involved in conducting a systematic review. Next slide. Next slide. Interpretation of systematic review, reporting of systematic review. So by way of introduction, we know that there are basically two types of research. We have primary research and secondary research. Primary research consists of basic research, like in the animal science, applied research, things like epidemiological studies, behavioral studies, outcomes research, health services research, and clinical trials. But we have the other type, which is called the secondary type of research, that deals with literature review, narrative review, systematic review, and meta-analysis, and scoping review. What essentially they do is that they aggregate data from primary research to arrive at secondary research. Next slide. There is this hierarchy of scientific evidence that we are all familiar with, starting from the bottom of the pyramid, where we have animal and laboratory studies. We have studies that does not require any design, like case report, case series, narrative, expert opinions, and editorials. Then we now go to those who have some form of design. We have the non-experimental observational studies and experimental studies. All these ones are still primary studies, like our randomized control trials, your core studies, case control studies. They are all primary studies. But at the top, at the second to the last top of the pyramid, we have systematic reviews followed by meta-analysis, and the last is the clinical practice guidelines, which ordinarily we depend on the result of meta-analysis. So next slide. Why do we need systematic reviews? Large amount of studies have been published in the last few decades in biomedical journals. And because we have so much large number of studies, it makes clinical medicine increasingly complex and difficult to make some clinical decisions. So available studies that we call the primary studies are often heterogeneous in terms of study design, subjects under study, operational quality, and different ways of handling research questions. Hence, the need for a secondary type of study. What is systematic review? It is a review of the evidence on a clearly formulated question using systematic and explicit methods to identify, select, and critically appraise relevant primary studies, and to extract and analyze data from studies included in the review. Or, in simple sentence, a summary of primary studies aimed at addressing a specific problem on pre-specified criteria. So you will agree with me that systematic review is to aggregate data from primary studies. So why do we need a systematic review? These are the reasons. Number one, to keep abreast of all previous and new research, because with systematic review, you know the evidence before now. And when new evidence comes up again, that we have to be upgraded. So that is why you be abreast of new findings, new ways of treatment, that will better the outcome of the patient. Another reason is that we want to sometimes we have to discontinue the old treatment, which might be outdated, harmful, or less cost-effective. We know the issue of treating malaria. In those days, we used to use chloroquine, but now we are now using artemisinin-based combination therapy. These are all based on systematic reviews and meta-analysis. Then we again need systematic review to draft guidelines for health and social interventions or treatments. Another reason is to arrive at a consensus when we have conflicting evidence in the literature. So then, because there is so much information overload, there will be need for synthesis so that we can have clear-cut guidelines on how to treat illnesses. Then it saves cost of healthcare. A little bit digression into the history of systematic review and meta-analysis. In 1904, a scientist called Carl Parson combined studies to show the efficacy of the typhoid vaccine. Then in 1972, Archibald Cochrane emphasized the need to review all medical topics. And in 1976, Jean Glass coined the term meta-analysis. And of course, in 1993, Cochrane collaboration was established. What are the steps involved in conducting a systematic review? Number one step is to have a clearly defined research question and objectives. The research question should be feasible, it should be interesting, it should be novel, it should be ethical, and should be relevant. Therefore, a clear, logical, and well-defined research question should be formulated. I will discuss this with an example in the next few slides. What are the two common tools that we use in formulating research question? We have the PICO format and we have the SPIDER format. The PICO format is used usually for quantitative evidence synthesis, where P represents the population of interest, I is the intervention in form of drug or vaccine, then comparison may be in form of comparing a drug with a placebo and the outcome. Whereas for the SPIDER, which we use for qualitative and mixed method study, we have S as a sample, P as a phenomenon, I is phenomenon of interest, D is the design, E is evaluation, and R is research. Next slide. So an example of a research question for systematic meta-analysis based on PICO is, for example, how is the safety and immunogenicity of Ebola vaccine in human? We see from that question, that research question, that P there represents the healthy subjects, which is the human. Then I represents vaccination, and C, which is the comparator, represents the placebo. While O, which is the outcome, represents safety or adverse effects of the vaccine. Following this first step, it is advisable to register the title to guarantee transparency and protect from duplication problems. If we don't register our title at this stage, it is possible that somebody else may be working on this same topic. And of course, if that person registered before us, that means that we cannot go ahead and do that systematic review anymore. So the next step in systematic review is preliminary research and idea validation. Why do we need this? We need it to identify relevant articles that we're going to use for our study, to ensure validity of the proposed idea, and to avoid duplication of previously addressed questions. If this work has been done before, there is no point in reinventing the wheel. So it is at this stage you may have to drop it because that particular question has been addressed severally and they've come up with conclusive evidence. To ensure there are enough articles to conduct the study, and while you are doing preliminary research and idea validation, you start with a simple search in PubMed or Google Scholar with search terms like Ebola and vaccine. Next slide. The next stage in conducting a systematic review is to plan the eligibility criteria. This still will be based on the PICO approach, the study design, and the dates. The exclusion criteria will be those topics, those papers that are unrelated to what you are discussing, duplicated papers, unavailable full text articles, and abstract-only papers. Let me, at this stage, let all of us know that we don't use abstract-only papers or articles that are not full text to do systematic reviews. Exclusion criteria should be stated in advance to refrain the researcher from bias. Then inclusion criteria are articles with the target patients. In this case, we are talking of Ebola virus. We are talking of vaccine used in Ebola virus. Then investigated interventions and comparison between two studied interventions. Next slide. Hello. Yes. For the chosen topic, inclusion criteria can be any clinical trial evaluating the safety of Ebola vaccine. And with this, there should be no restriction with respect to the country where these articles have been published. There is no restriction to the patient's age. There is no restriction to the race or the gender or the publication language. Even in Chinese, Spanish, all papers that can be gathered in respect of Ebola vaccine safety should be aggregated. And of course, there will be no restriction to the date of publication. The exclusion criteria can be study of Ebola vaccine in non-human subjects or in vitro studies, study with data not reliably extracted, duplicated, or overlapping data, non-full text articles, abstract-only articles, conference proceedings, editorials, case reports, case series, and systematic review. The Prisma flow diagram of study screening and selection is used at this stage. Prisma is preferred reporting items for systematic review and meta-analysis. The next slide is showing us what it is all about. You see at the top of the table, we have identification, where you identify studies searching through some databases and additional records identified through other sources. You can see here that we have about 170 from these records and the other one additional 10, making a total of 180. So we now screen. When we screen, we have 142, and then we exclude 28. Then out of the ones that we have screened, we now apply the eligibility criteria to get full text articles that are assessed for eligibility. This one is giving us 129. Then, of course, we now work on this one. So studies included in quantitative synthesis will now end up as 51 after we have been able to aggregate the data. Then the next stage in systematic review is our search strategy. We have to plan our methods. Standard search strategy is to use PubMed, which can be modified later to each specific database. And this is based on our research question that we have mentioned earlier in the very first stage of our systematic review. Then it is constructed to include free text terms. It needs assistance of an expert in the review topic field, and is not advisable to use terms for the outcome to avoid non-retrieval of eligible studies. The next stage in our systematic review is to search databases, import all results to a library, and export to an Excel sheet. At least 2 databases have to be searched according to AMSTAR guidelines, which is a measure tool to assess systematic review. The ordering of the database depends mostly on the review questions. For example, this being a clinical trial, we rely mostly on Cochrane, randomized control trials, international clinical trials, and registry platform. About 12 databases are proposed in this case, and these ones are as listed: PubMed, Scopus, Web of Science, Global Health Library, Virtual Health Library, Cochrane, Google Scholar, clinicaltrials.gov, MRCTs, Popline, and SIGO. Some databases do not support the use of boolean or quotation. Otherwise, there are some databases that have special searching way. Hence, manipulation guides are available for each. The next stage is protocol writing and registration. We should remember that we have previously registered this protocol when we were actually at even the conceptual stage where we had our research question. So having previously registered the protocol to guarantee transparency and protect from duplication problems, we recommend that researchers send the protocol to the principal investigator for revision before being uploaded to registry site. And we always advise for systematic reviews that it should be registered in Prospero. That is the International Prospective Register of Systematic Review is the registry site that is recommended. And it is because it is easier to upload. And even at that stage, one can actually publish the protocol. It's a publishable document that can be cited at that level. Then the seventh stage is the title and abstract screening. Decision to select retrieved articles for further assessment are based on eligibility criteria to minimize the chances of including non-relevant articles. At least 2 to 3 reviewers will work independently to reduce chances of error. 3 is even better than 2, as 2 only will have different opinions from each other, so they cannot take a decision, sometimes making the third person very crucial. The duplications, if found, will be manually removed, and the principal investigator, following discussion and consensus, takes the final decision on articles that are in doubt or being included. If some articles are eventually excluded, clear reasons should be stated for excluding those articles. Then the next is full text downloading and screening. Many search engines provide links for free to access full text articles. If not found, some research websites like ResearchGate, where we can make direct requests to the authors for full text, can be explored. A number of times when we go to ResearchGate, we can actually have direct contact with the author of that paper, and I'm sure by the time we write and let the person know why we want the paper, he or she will be free, will be readily available to send the free text articles to us. Sometimes we have to explore archives of wanted journals, then contacting the PI for purchase if available. That is, if we cannot get the articles free of charge. 2 to 3 authors are also involved in this, and in case of disagreement, final decision will be reached after useful discussions. Then the next stage is a manual search. We exhaust all possibilities to reduce bias for retrieval of reports previously dropped from the first search. There are basically 5 methods of manual searching. We have searching references from included studies, searching references from included review, contacting the authors, contacting experts, and looking at related articles in PubMed and Google Scholar. There are basically 3 methods to increase and refine the yield of manual searching. The first is searching referencing lists of included articles. The second is performing citation tracking, where reviewers track all the articles that cite each one of the included articles. This might involve electronic searching because of the volume of articles that will be involved in the search process. Then follow all related to or similar articles. Individuals are tagged and assigned a distinct method out of these 3. So for people to participate in systematic review, it involves a large number of people, minimum of 3, 4, sometimes it can even be up to 5, up to 6, 7, 8, 9, 10, depending on the task assigned to each. Then the next one, which is the 10th stage, is data extraction and quality assessment. Data collection from included full text articles in a structured extractions Excel sheet. So by the time we have been able to get all these articles together, we will now need to have an Excel sheet that has been previously pilot tested for extraction using some random studies. So we extract both adjusted and non-adjusted data, as this gives the most allowed co-founding factor to be used in the analysis later. This process should be executed by 2 or 3 independent reviewers who have not even taken part in the review from the beginning. So independent, but they are still in that review team. So the sheet is mostly classified into the study and patient characteristics, the outcomes, and qualitative assessment tool. A variety of tools are available for the qualitative assessment depending on the study design. We have the ROB2, Cochrane tool for RCTs, which is the risk of bias tool for RCTs. We have the National Institute of Health, that is NIH, for observation or cross-sectional studies and cohort studies. And we have the CARE for case reports. So these are all available tools that can be used. As in this case of Ebola study, which is an observational study, to evaluate the risk of bias, the reviewers should rate each of the 14 items into dichotomous variables as yes, no, or not applicable. A score of 1 is given to yes when we are reviewing the articles, and a score of 2 is given to no or not applicable. All scores are aggregated for each item and added to classify each paper as poor, fair, or good conducted study. We should not forget that not all studies that we even gotten will be good enough for us to use when we are actually aggregating data for systematic review. Some articles are very poor in methodology. Some articles are very poor in sample size. They have very low sample size. Some have very low power and all that. So there are a lot of things that we need to look into when we are assessing each study. So a score of 0 to 5 is rated as poor, while 6 to 9 is rated as fair, and 10 to 14 is rated as good. The following information can be extracted from each publication: name of authors, country of patients, year of publication, study design, the sample size, follow-up interval after vaccination, time, efficacy, safety, and adverse effects after vaccination. Next slide. The next is data checking. This is recommended due to expected human error and bias. We are all humans and we are all prone to errors. So it is never too much to check data. All included articles are compared with their counterparts in an extraction sheet to detect mistakes in data. This will usually be performed by 2 or 3 independent reviewers that did not participate in the extraction of those articles. Where resources are limited, however, each is assigned a different article originally extracted. Then, of course, we keep on talking about data. Again, we need to do double data checking for more assurance on the quality of results. The analyzed data should be checked to allow an obvious check by the principal investigator of the study. Then the last stage is manuscript writing and submission to a journal. This is based on 4 scientific sections: introduction, methods, results, and conclusion. After finishing the writing, the team should send it to the principal investigator to revise it well, choose a suitable journal for publication. This is a typical systematic review skeleton, and this will be applicable to all systematic reviews. You have the abstract, you have the background of the study, you have the objectives, criteria for selecting, for considering studies for this review, types of participants, types of intervention, types of outcome measures, types of studies, characteristics of included studies, search strategy for identification of studies, methods of the review, description of the studies, methodological qualities of included studies, results, discussion, conclusion, implications for practice, and implications for research. There is no need doing a systematic review if there will not be implications for practice and for further research, because the medical literature, the medical world is evolving every day with new technologies, with new treatment, with new approach to handling issues. Then, of course, this will be the last part of the systematic review skeleton: internal sources of support, external sources, potential conflict of interest, acknowledgements, contribution of each reviewer must be clearly stated. A synopsis, table of results, and references to studies included in a particular review. When we have a systematic review in our hand, what are the questions to consider when we appraise a systematic review paper? The first is, did the review address a clearly focused question? That was where we actually started from with our PICO format or our SPIDER. Did the review include the right type of study? Did the review try to identify all relevant studies? And this will be all encompassing. Did the review assess the quality of all studies included using those checklists that we discussed earlier on? If the results of the review have been combined, is it reasonable to do so? How are the results presented and what are the main results? How precise are these results? Can the results be applied to our local population? Were all important outcomes considered? Should practice or policy change as a result of the evidence that we found in this review. These are the way a systematic review should be appraised. So what are the challenges with systematic review? The first one is evidence into practice. Yes, there is already evidence based on all the reviews we have done, but are we able to put those evidence into practice? That is a very big challenge, particularly in the developing world. Many interventions reviewed cannot be implemented in resource-poor countries. And this we know because of our low, because of our, let me say, our lackadaisical attitude to addressing health issues in resource-constrained countries sometimes. Most interventions reviewed so far don't reflect developing world priorities. There are very few studies have been conducted in developing countries for obvious reasons. Number one, access to studies, access to databases that will be able to give us all the articles we want to do systematic review. Most developing countries researches found are excluded for lack of quality. A number of times we don't do high quality studies. And of course, if we don't do high quality studies, it is not likely such studies will be included when systematic reviews are being conducted. Then publication bias. There's always tendency to publish studies that have demonstrated statistically significant results, even though some statistically insignificant findings are clinically significant. What are the potential limitations of systematic reviews? We have risk of bias, selection bias, inadequate blinding, attention bias, physical heterogeneity. You see, when we talk of heterogeneity, we are picking studies that have different methodologies, different inclusion criteria, different exclusion criteria. Some studies we do studies between in adults, some we do in adolescents, some we do in very old age, some we even do in children and adolescents and old age together. So we don't have, so there is always this problem of heterogeneity in our studies. So by the time they pull all those things together, all these ones will make our systematic review to be limited in application. Then imprecision that can lead to type 1 error or type 2 error. The next part of the presentation is the statistical analysis, which otherwise is referred to as meta-analysis. Next slide. You can actually do systematic review without doing meta-analysis, but you cannot do meta-analysis without systematic review. So what is meta-analysis? It is a quantitative approach for systematically combining results of previous research to arrive at conclusions about the body of research. Meta-analysis is a statistical technique or a set of statistical techniques for summarizing the results of several studies into a single estimate. Meta-analysis is the process of combining a number of separate studies to produce one super study. For example, we might have 3 separate studies with sample sizes of 40, 80, and 150. When combined together, we get a super study with a sample size of 270. This is the relationship between systematic review and meta-analysis, which I've discussed earlier. I said systematic review is the process of undertaking the reviews, and meta-analysis may be one outcome. And not all systematic reviews include meta-analysis, but all meta-analysis are found in systematic reviews. We have basically 3 types of meta-analysis. We have the cumulative, retrospective, and prospective. The prospective one is, criteria and protocol selection is started even before studies of interest are published. It actually has very low bias in terms of the outcome. Whereas a retrospective study is actually the one we commonly do. We go into studies that have been done many years ago and pull them together. Whereas cumulative meta-analysis is an analysis where new studies are added every time a new study is published. So there is meta-analysis that is repeated on a regular basis. That is cumulative meta-analysis. Next slide. Why do we need meta-analysis? Sometimes we have contradiction in different studies, contradictory results, okay? And multiple studies done on the same focus study topic will generate overwhelming data and the need to summarize in a method that is scientifically acceptable. Next slide. How do we conduct meta-analysis? Like I said, systematic reviews will be needed to proceed to meta-analysis. So the very first part is to do systematic review, then a qualitative approach for systematically combining results of research to arrive at conclusions about the body of research. So the first thing is, after you have conducted systematic review, you now evaluate your data for heterogeneity. Variability among studies could be clinical, methodological heterogeneity, and statistical heterogeneity. I've discussed this in my previous slide. And pooling of data now using a forest plot. So we now graphically represent meta-analysis in what we call a forest plot. This is usually accompanied by a table listing references, lead author, and date of the studies included. The right-hand column is the plot of the measure of effect, which I'm going to show in the next slide, where we find the odds ratio represented by a square with confidence interval represented by horizontal lines. And there's a black diamond at the bottom of the graph that shows the average effect size of the total studies combined. Next slide. Yeah, this is a typical result of a meta-analysis. And this is what we call the forest plot, the one on the right of the screen. So we can see that we have 1, 2, 3, 4, 5, 6 studies here, and they have all been aggregated as total here. So we can see the mean, the standard deviation. We can see the mean, the standard deviation, 95% confidence interval here. We can see the odds ratio, risk ratio in some cases depending on the type of study. Then, of course, this is now the effect in relation to the total. So like we said, this horizontal line represents the confidence interval. Then the small box here represents the effect of this study in relation to the other studies. Then this is a diamond that is the aggregate of all the studies, that were conducted. Next slide. So, interpretation of forest plot. Names on the left will be first author of the primary study. The black squares represent the risk ratio or the odds ratio of individual studies. Then the black square represent the weight of each trial. Then horizontal lines represent 95% confidence interval, like I said earlier on. And the vertical line is the line of no effect, where the odds ratio or the risk ratio is equal to 1. Then the diamond is overall treatment effect, and the center of the diamond is a combined treatment effect, while the tips of the diamond represents 95% confidence interval. Well, this is just to illustrate forest, where you have different sizes of trees. Some are thin, some are fat, some are very fat. So next slide. What are the strengths of meta-analysis? It uses explicit methods which limits bias. It draws reliable and accurate conclusions, and is the best form of evidence. It's very useful in decision making for clinicians, researchers, and policymakers. Generation of new hypotheses about subgroups of study, and it increases the strength, the precision of the results, and identifies the existence of evidence gaps and methodological problems within the body of literature. If studies are too heterogeneous, a meta-analysis should be avoided, as the result may be meaningless and any true effect will be obscured. In other words, if you have so much of disparity in studies, it's not likely to be able to make any meaningful report out of it. Then publication bias is a shortcoming of meta-analysis, because we tend to publish results that have positive outcome. So garbage in, garbage out, that's another limitation. Meta-analysis that includes low-quality studies with bias will be biased and incorrect. So meta-analysis cannot improve the quality of reporting of the original primary studies. So that is why primary studies should be conducted properly. I'm sure we are familiar with this logo, which is typical when you see a study that has meta-analysis done. You can see this circle. You can see that there are 1, 2, 3, 4, 5, 6, 7 studies here. You can see the confidence intervals, the lines. The vertical line is the line of no effect, and this diamond is the overall effect of all these studies combined. Okay. In conclusion, once the PICO question is developed with determination of eligibility criteria, an exhaustive search with the following steps: predetermine relevant database, search keywords, expand the search by also searching the reference list in the studies obtained in the previous steps. Okay, next slide. 2 or 3, that is search results, and of course, once you search a primary article, you still have to go to the reference list again to search articles under the reference list. So that second and third stage are sometimes called snowballing and reverse snowballing. This process continues until there is evidence of repetition of search results. And this is important to, again, remember that you should include unpublished studies, gray literature. Gray literature can be things maybe like term papers, some studies that, or some papers that are with Minister of Health, Minister of Social Development, things like they are gray literature because they are not indexed. So that's why they are called gray literature. And you could actually find some useful things there too, because I'm sure before they can have policy formulation, they will have done studies before they can arrive at policy formulation, which will be domiciled in Ministry of Health or any of those ministries that have to do with health. The use of at least 2 screeners is recommended to reduce or eliminate bias. Next slide. What have we learned from the Cochrane collaboration? Life is full of trials. Thank you very much for your attention.
Very much.
Thank you, sir.
Thank you.
Thank you for all the comments. Thank you for all the questions. Thank you for Professor Adewunmi for speaking to us and teaching us, and for volunteering to contact the Cochrane team. And thank you, dear Provost, for saying yes right here and now. You didn't even wait for us to come to you, just said yes. And thank you, Professor Njokama, for letting us know that our Provost would rather hide, but thank you for bringing him out. Thank you for today. I think it's been a good day. It's been a good outing. We have learned a lot, and we're going to take it further. So the next lecture will be taken by no other than our own Professor Ogun. He'll be teaching us about randomized control trials. And after that lecture, the next series of lectures will be focused on data analysis in different kinds of studies. So we look forward to receiving you. Don't forget to copy the link in the chat room if you haven't, so that you can have access to the previous lectures and to this one when it is available. Thank you everyone for joining me, and have a lovely evening. Good night.
Yeah, good night.
Good night. Thank you.